For those of you that don't know me, my name is Jennifer Lau. I'm the president and co-founder of BEAR, and which stands for Biliary Atresia Research and Education. And just to kind of give you just a little bit of history, BEAR was founded in 2022 by myself and my co-founder, Jordan Sarbaugh. Which she unfortunately could not be here tonight, so she sends her regards. Anyways, welcome. I do also have with me my partner in crime in this whole thing, Maria Bell. She is one of the BEAR board members and part of our patient advocacy and policy networking area. And then we also have two physicians here with us who have been working with us every step of the way as well. We have Dr. Sanjeev Harpavat from Texas Children's and also Dr. Tebyan Rabbani from Stanford Children's. So just want to thank them as well for taking the time to be here with us tonight and give you guys good information and also help answer questions that maybe Maria and I just do not have the bandwidth to answer. So this is BEAR's actually first town hall meeting in regards to, newborn screening that we are doing. Okay, so the first thing that we really want to talk about for those that might not quite fully understand newborn screening, what is it, right? So here with the newborn screening, it's a process of checking babies to identify certain health conditions that in serious health conditions that can maybe really benefit from early treatment and or intervention. So some of you may have remembered, when you had your child right away, they took them off and kind of did that heel prick of blood work to send that off for testing. And to the next bullet point, basically, that screening happens anywhere from the first 24 to 48 hours after birth. Typically, most states use only one screening model. In this model, they're only screened once between that 24 and 48-hour window. And it looks for all conditions that are listed on the state's newborn screening panel, which we'll get into a little bit later. So there are 13 states that use the two-screen model. And in this model, babies are screened 24 to 48 hours old, and then they're screened again at the 1 to 2 weeks old. And the second screen usually happens like either at your primary care physician or pediatrician's office. So next is regarding early detection and biliary atresia. And I want to bring this to the forefront because in speaking with a lot with patients and families and within the community, um, this is a huge pain point for us, right? So when discussing with other families around, the United States, around the country, and talking about what their journey with biliary atresia has been like, it's really the lack of early detection within this disease. Although our journeys can be very different from one patient to another, there has been a commonality or similar, challenge. The challenge is getting our children tested at the right time and early. Um, the lack of newborn screening recommendations across all medical systems is really detrimental to the outcomes in diagnosing children in biliary atresia and then treating them. And then the late detection obviously leads to more significant morbidity and mortality. So really, why is newborn screening really important for biliary atresia children? It's really simple. Biliary atresia is presented at birth. There's a test. There's treatment available. They have the Kasai, and treating early, ideally 30 days before life, can change the outcome. So, and that would be in regards to having a successful or non-successful Kasai. Some key points is that transplant is life-saving, but the initial goal is really to try and avoid liver transplant and have the child, keep their native liver. Post Kasai survival with native liver is 40 to 55% at 5 years and 35 to 45% at 10 years. There is no split liver policy, so split transplant liver policy here in the United States. We also have limited living donors, and then also lifelong immunosuppression, including compliance issues once our kids kind of get older post-transplant. And I think these points down here, if Dr. Rabbani or Harprevat, if you guys, have some key points in regards to this or would like to speak to this, that would be great as well.
Yeah, I'll just add that exactly what Jen just said. So while transplant is an option, sometimes an inevitable option for some kids, we can potentially postpone that, or even there's still very early data because we're doing this, getting them to Kasai earlier and earlier, but maybe even save them from ever getting transplant, which meaning the immunosuppression that they're on, they wouldn't need to be on those medications that have a lot of different complications, as I'm sure a lot of people on this line already know about, whether it's infectious risks or cancer risks or those kind of things that we can potentially negate. So essentially, just as simple as says, VA's present at birth, we have a test. This treatment is great as long as we get there early enough. The Kasai, less than 30 days is ideal.
Thank you very much.
So to provide as many babies in the United States as possible this chance at an early Kasai and a delayed or avoidance of transplant, our goal with our newborn screening initiative is to completely eliminate late detection. So we do that primarily two ways. In the left and right of the schematic, you'll see that we have the federal level work and then the state level work. Those are, again, our primary modes right now. The federal level work means that we are working to nominate biliary atresia to be added to what is called the Federal Newborn Screening Recommendations List. I'll talk about that in detail in just a moment. And then at the state level, we'll be leading efforts in a state-by-state manner to have biliary atresia added to newborn screening panels in states. And those panels are different from the federal recommendations. In some states and in other states, they're the same. So it's a bit complicated, but those are the two primary modes of attacking this problem of late detection. There's also some grassroots work that is beginning with BEAR, and that includes exploring options for not strictly newborn screening, but just early detection recommendations through medical societies, nursing societies, and that sort of thing. So yeah, those are the three ways that we're attacking the problem. So we'll start with the federal breakdown. The schematic is most easily read rather from the bottom up. So we'll start at the bottom where you see ACHDNC. This stands for the Advisory Committee on Heritable Disorders in Newborns and Children. This committee was congressionally appointed and funded in the early 2000s and is in operation still today. It is the governing body for the recommended uniform screening panel that I mentioned previously on the previous slide. We affectionately call this the RUSP. That's what I'll say for the rest of our talk, the RUSP. And again, the committee oversees this panel of conditions. They oversee conditions that can be added to it, the entire process for that. And they use this list, this panel, as something to offer states, and states are not required to follow it, but I'll explain in a bit why it's still relevant to screening in general. So the ACHDNC lives within the Health and Human Resources Administration, HRSA, and that group is within the Federal Department of Health and Human Services, HHS, at the top of the schematic. So if a condition is recommended by the ACHDNC, it will go to the secretary, the presidential appointee secretary of HHS, He or she receives those recommendations or that particular recommendation for that particular condition, and that secretary has the final sole decision-making power, excuse me, about whether or not the committee will officially adopt this condition to be included on the RUSP. This entire process at the federal level is complicated and lengthy. We're committed to it, but just to set everyone's expectations, it can go as swiftly as 3 to 4 years, and it can take as long as 10 years for some conditions to work through this entire process. There's both internal and external review processes within it. So yeah, it's a long process, but we'll get to some of those details in a moment and where we are in that process. So we started that process on September 8th, 2023, or 2023, excuse me. Bear submitted our official nomination package to that committee, again, the ACH-DNC, requesting essentially that we be added to the RUSP, providing all of the medical data, providing advocacy paperwork. And again, the committee operates within the Department of Health and Human Services. For a timeline of what happened after we submitted that initial nomination package. That was in September of 2023. November of that year, we had our first meeting with committee representatives. They gave us some productive feedback. So we worked on revising our nomination package according to their feedback throughout the spring of this year. In early May of this year, Bear provided testimony at one of the committee's quarterly meetings in support of our application. But in mid-May, we were notified that the entire application process was changing and that they needed us to prepare a completely different and new package to nominate biliary atresia to the RUSP. So Bear worked swiftly to prepare that new package, submitted it at the first opportunity when basically when applications were open again for acceptance on May 31st of this year. We had our meeting with representatives from the committee in July to discuss that application or that nomination package, and then provided more testimony at another quarterly meeting in August. And so what we would like to do specifically tonight is not only explain to you how the process of advocacy for newborn screening for BA works, but also give you some insight into the kinds of things that we are the kinds of things that are happening in these meetings with the committee so that you understand some of the challenges that we have as an organization, some of the things that, if any of you become involved in state coalition efforts, some of the things that may come up in those discussions and meetings. In July, that meeting that we had with representatives from the committee, they let us know that our application was not acceptable to move forward in the nomination process at this time, and they gave us some direct and clear feedback about that. I'll just go through those quickly here on the screen. The first concern they had was that our point of care test is challenging to implement. And that is because, as I think Jen mentioned in an early slide, most conditions, like almost every condition that is currently screened for, either recommended federally or screened for across states, is done with a dried blood spot card or the heel prick that you experienced when your child was born. So biliary atresia is screened with point of care. And so it's difficult to implement this in a screening recommendation because we have to work with hospital protocols and not state labs. We have to make sure that patients have follow-up at 2 weeks. So that's the first issue that we are trying to sort through. The second is that we have some false positives in our current studies that need some more explanation. The committee likes to see an almost 0% false positive rate. So our team is working on that. They also mentioned that our cited pilot study is not necessarily a population-based study, and they have a definition for that we are still working to understand. It's not published anywhere, so this is a challenge not only for them, but for us. Let's see. Fourthly, our references that argue for the early Kasai, that is a Kasai before 30 days of life, to improve outcomes, lack something that they call high certainty. So something that we're learning with the federal committee is that there's very specific language that they use in their policy matters for newborn screening. So we are working to understand what high certainty is and how we can reflect that clearly in the references that we cite in support of our argument. So they also mentioned that our screen lacks consideration of potential harm to parents and caregivers whose baby proves false positive. And lastly, the committee chair was not receptive to our stated explanation that when we screen for biliary atresia, this could help in diagnosing other cholestatic liver diseases. He really wants us to just focus on biliary atresia and not think about too many other things in our nomination process. So that was a summary of our meeting. Again, all challenges that we can address, but this takes time and effort, and we are working on that. Okay, so that's our federal work. Secondary to that is our state work. I shouldn't say secondary to that. Really, we're working on both of these things concomitantly. So I just want to say at the outset that some people might say, well, why are you even leading, state level efforts if there's this federal committee? When I first started working in newborn screening, that was my first question. Well, if there's this federal committee and they produce this recommendation for all states, why don't we just do that? The reason is that not every state implements federal recommendations. Some states are very happy to carry out their newborn screening programs independent of the federal committee. This means that they may look at the federal committee recommendations and include some of those conditions, but they really want to be independent of the federal committee. So to carry out this work, meaning going state by state, and looking for how we can add biliary atresia to a state newborn screenings panel, we will need, for each state, in-state screening data. We'll need providers to help us with that, and patient family advocates to help us with that work as well. And in time, following data compilation and presentation to various health departments, we will need patient testimonies from centers within those states that we can use for media coverage to help with our case. And that's really because many states add conditions to their newborn screening panels by legislative action. Some states it's done by rule, meaning you work strictly with the state health department and their newborn screening committee. And in other states, you work in part with the newborn screening committee, but then you also need to have legislation drafted and passed through that state's congressional process to have an actual law added that a particular condition should be in their panel. And that's where media becomes particularly important in those states. So work to gather newborn screening data. Again, the first thing that we need to do to get started in any state is currently already going in Louisiana, Texas, and California. And in addition to that work, Jen and I and others are canvassing additional states where we can begin work. One that's high on our radar is the New England Newborn Screening Program, because it is sort of an umbrella program for a number of states: Massachusetts, Maine, New Hampshire, Rhode Island, and Vermont. So a lot of what we're doing right now, again, is mapping out the state work. So which states are adding conditions by rule through the health department, which states require us to add it by law through legislative action, where do we have interested providers where we can get data, and then building over time state coalitions of providers and family patient advocates to build a sort of on the ground effort for that particular state. Okay, Jen, do you want to close us out?
Yes, and I just wanted to let everybody know, I know this was a lot of information and we do have a Q&A time, but really, so what's really next for Bayer and newborn screening for biliary atresia is Bayer has basically put together and established a diverse panel of stakeholders, which is our newborn screening task force, to help advise and conduct and lead clinical and advocacy efforts for Bayer and newborn screening initiatives. So any kind of ideas or ways to kind of work around some of these hard processes to break or whatnot. The task force is really put together to kind of help drive and help us think outside of the box, so that we're really looking to no stone is left unturned, right? We're really starting to really look at many different ways in how we can approach, just testing more babies, and making sure that biliary atresia is on the radar. And then, as you heard Maria give a great definition and information on our state action plan is to just continue to collaborate with providers, patient advocates, our task force to help lead efforts for biliary atresia to hopefully be added to state newborn screening panels. And then, as you heard earlier, our federal action is to continue efforts in working with HRSA and the advisory committee on towards adding BA to the RUSP. So we've kind of broken it down into these three sections thus far. So now is time to really help answer some of the questions that you may have, even ideas that you may have. I'm going to stop sharing the screen here just so I can see everybody and be able to capture even in the chat if there's questions, if you don't feel comfortable, saying anything. But I will say this prior to going into Q&A here, if Dr. Harpervad or Dr. Robani would like to have, add any comments or any information that would be pertinent for the group tonight, please feel free and chime in. And if not, we'll go into Q&A.
Jen, can you hear me? Is it coming through?
Yes.
Perfect. Okay. Yeah, thank you. I think that summed it all up. I think the big picture story is we're taking multiple approaches, and there's no straight shot to this. So it's going to be, it's like a beast in lots of different areas we're trying, but I think the approach is the more sort of opportunities and approaches we can take, the more it'll slowly get in the consciousness of, ultimately, it would be nice at the federal level, people would care about this and think about it. But I think it's a process. And I think we're learning that slowly as we go. And some avenues might hit first and some might take some time, like the federal one might take some time. But it is a process. I wanted to answer also the question, the current false positive rate. It's actually it's a funny question, because when we say false positive, it means people who are caught by the screen, but that don't have biliary atresia. But one could argue very quickly that, let's say you have another condition called Alagille syndrome. There's definitely case reports in the literature of children coming in with Alagille syndrome with big bleeds because no one caught it on time. And so these are diseases that, and also for nutrition and for other things, these are conditions that can benefit from earlier detection. So in that false positive rate are other liver diseases or liver conditions. And the false positive rate is around, I think the way you can think about it is 1 out of every 1,000, 0.1%, which means that biliary atresia, it's 1 out of every 15,000. So for every child with biliary atresia, you might get a series of Alagille syndrome and other conditions. That's kind of a rough estimate. We would have to push back hard on this. And I think it's just a matter, from a pediatric hepatology standpoint, we don't consider these false positives as a mistake in the system. We actually think they're actually a really good thing in the system. So these are certain things we have to push back on. I mean, it's important also, as Maria mentioned, it's one person's opinion. He happens to be the chair of the committee, but it's one person's opinion and not exactly the most sort of yes type of guy.
All right. So I am going to open it up to the floor here. Dr. Harpervad already answered one of the questions in the chat about the false positive percentage. Were there any other kinds of questions? Yeah, Cody, go ahead.
My question might be more for Maria from like a policy standpoint. Are there some allies that are with ACH-DNC that you visited with? I see Dr. Cologne's terms out in 26. So are there like some current members that we could kind of lean on? And because one of them will be likely be a chairperson?
Great question. It's something that we're still learning. As Dr. Harbabat said, it's a big process at the federal level. We do have someone on the committee who has spoken with us in a more favorable manner about our application, and we intend to have continuing conversation with him. He's served on the committee for at least 10 years, if not longer. So he's a wealth of information, and he seems like a person who's really interested in helping groups move through the process. As Dr. Harbabat said, the current chair is not quite the yes sort of guy. But maybe that's his job, to provide all the challenges to us so that our application is as thorough as possible when it comes to a full committee review. So that's the answer. It's a yes and no answer. Yes, we have someone that we're going to reach out to, and no in the sense that we're still getting to know all the members, still getting to understand the process, still trying to understand who we are actually permitted to reach out to directly, who we're not permitted to reach out to. So yeah, great question.
It looks like Brittany Harris, your hand is up.
Hello. Hi, everyone. Question about newborn screening. So my daughter was born with biliary atresia 2022. She was jaundiced at birth, went through photolite therapy, and that was the end of that for, a week or two. At birth, if a child presents with jaundice, could a stepping stone be to have a system in place where that child must follow up with the hepatologist? Because if it is present at birth, or if it's, if there's that test we could see, I guess, can someone speak to that process of setting a child with jaundice up with the hepatologist right away? Because as a new mom, I really didn't even know what jaundice was. I was so wiped out from, labor, and, I'd like to hear what someone has to say.
Sonia, I don't know if you want to take this or I can.
Yeah, go for it. Go for it.
All right, awesome. So that is a fantastic question, Ms. Harris. So essentially, babies can be jaundiced at birth, and what a lot of babies are, and it's most of the times what the neonatologists or the pediatricians are seeing are like what we call physiologic jaundice, where there's a lot of red blood cell turnover, which breaks down and creates this bilirubin, high unconjugated bilirubin in the bloodstream, which can sometimes cause babies to be a little bit yellow. Now, another cause of that jaundice can be that direct or conjugated bilirubin. Now, that can be a sign of liver disease. It can be a sign of biliary atresia specifically. So what the most important thing to do is in another aspect that we're asking a lot of pediatricians to do at this point is to get both that, while you're getting the total bilirubin, also get that direct or conjugated bilirubin as well, because that's going to tell us more information about the baby's liver. If that yellowing is due to just a high total bilirubin because of that physiologic or breast milk jaundice, other reasons, or is it due to another reason, like something going on in your child's liver? And then at that point, we're actually working on an educational website for pediatricians to go on. We didn't want to mention it here just yet, but it's going to be a very, very useful tool for pediatricians and neonatologists across the US and across the world, really, to go on there, put that direct bilirubin level in there, and the age of the baby, and then it can tell them, should you be worried about biliary atresia or should you not be worried about biliary atresia? That website, it's going to be called bilyscreen.org. We're really, really excited about it. Actually, Bear's backing and helping us build that website. And we're hopeful that with widespread use, those children can, once the pediatrician or the neonatologist puts that value in there, they will then go and contact pediatric GI or hepatology because that baby was found to have a high direct or conjugated bilirubin level. So we are working as well on that referral process to get them plugged into GI or hepatology. I hope that answers your question, Ms. Harris.
And Ms. Harris, I'll add on. So I think from a systematic standpoint, so you nailed it. We can't do it in the federal level quite yet, but that doesn't mean we just sit around. We got to find a solution, a pathway that we can start implementing now. And so what you're basically saying is, what we're asking people to do is, if they're going to draw a bilirubin on a child, it's actually not any extra blood or anything else to draw a direct. So it's just simple, draw a direct with the total, which is what they drew for your child. And then it'll be straight to the website, plug it in, and it'll tell you what to do. So it's as simple, it's literally no work on the provider's parts. Now, how are we going to do that? We have to get the word out, and we're taking the approach of doing it in, I guess, in locations, regions at a time. So this is something that we're trying to push out in Texas pretty soon. I'm not sure where Ms. Harris, where you live, but this is yet another model. So we could go through the federal, or we could do a more grassroots where we draw the borders of where we want to attack. But basically, to address exactly what you said, we have to be careful about telling if you tell a doctor to consult hepatology every time, they're going to protest, they're going to push back. And so that's why we've made this website. It'll be super easy. Everything will be easy, and it's exactly what you said. The challenge is getting it out now to primary care doctors. How do you reach the 60,000 or 100,000 pediatricians out there? And that's something I think Bayer can work on and try to help solve.
Thank you both. Those are really, really, truly amazing answers. And Brittany, that was a really great question, because I think all of us as parents have thought about that at one point in time. Just, why wait around for 2 to 3 weeks and then just, get to it and get to the answers. So, so I appreciate you asking that question tonight. Ashley and Taylor, I see your hands up. I don't know if you're both are on or which one of you are on, but hello.
We both are on. Hi.
All
How
right.
are you? Yeah, no, I just had a question going back to sort of the packet that y'all submitted, and this is sometimes my ignorance in research, but even when you're submitting things to certain committees, and sometimes it's just language, right, that you need to be using that is going to sort of get their pass, and sometimes it's not being as specific but very sometimes broad in that language. And so I was just curious, was that sort of what the message was in the packet, or was there a little bit more to it than pretty much what y'all presented? I guess I was looking more for the specifics on the type of language that was used.
So I'll just jump in really quick, and then Maria and Sunny can also, at first, we went into the application really thinking, okay, this is not a room full of hepatologists. They're not, GI hepatology physicians. So how do we break down the amazing knowledge from the clinical standpoint that Sunny knows, and how do we break that down into more of, if we were trying to explain things to like my husband, or, just in general, the general public regarding that. And I think we did do a pretty good job. You can't, there's only so much you can water down as far as data is concerned, and specific areas within the actual disease itself. I think that not where we struggled, I think where they struggled to understand was that we just, the two just wasn't connecting. We weren't, it's like putting a square peg in a round hole, and they were hoping that we were going to be that round peg to go into the round hole, basically. And I will let Maria and Sunny maybe speak more to that.
Yeah. Hey, Ashley and Taylor, you're absolutely right. There's a body of language that's expected for people in the newborn screen community. And I don't think that we missed the mark with our language in any sense. One way to think about it, and this has been explained to me multiple times from many different people who have spent 10 plus years in the newborn screen community and in their own rare disease, group processes with this committee. And that is that when the federal committee makes a recommendation, they send it to the secretary. The secretary usually approves it because at that point, there's, just been such rigorous work done to provide him a recommendation. They have to be able to say to every state in the union, here's this condition and here's how you screen for it. So with biliary atresia, we have some challenges, like I mentioned, because we don't have the dried blood spot card. There's not a gene directly tied to biliary atresia currently. And so because we don't have that dried blood spot card, we do not fit into their system, right? So they're not just looking at, is it worth it to screen biliary atresia? I think they're probably convinced of that. That's my own opinion based on our feedback. It's more like Jen said, the case of, fitting this peg into a square shape. We don't quite fit their system. So their advice to us is to start working on how we can fit their system. How can they as a committee take our disease state that doesn't fit the system they already use, hospitals partnering with state labs, for instance, how can they confidently say, here's biliary atresia, go to every state in the union? And so, like I mentioned in the meeting summary slide, there are some challenges. They need to kind of better understand that our false positives aren't a negative thing necessarily. We need to understand what they mean with certain phrases like high certainty in our early CASI improving outcomes argument. But really, this comes down to an implementation question. So getting at the implementation means going back to our population-based studies, revisiting those, maybe completely reimagining them, as Sunny said, or Dr. Harpavat said, looking at how we can go region by region, working in a sort of grassroots way with medical and nursing societies to roll out some early detection guidelines. And then ultimately going back to the committee and saying, okay, we think we have an implementation protocol that if you recommend us on your panel to all the states can easily, run with. So I don't know if that answers your question.
No, it did perfectly. Yeah. So I appreciate that insight.
Yeah.
Yeah, and I'll give you my take on it. And you guys can hear me, right? Okay, good.
Yes. Yes.
So my take on it is we were hosed from the start on this. We don't have we have a point of care test, and they don't like point of care tests. Like straight up, they don't like them. Point of care means that it's done at the bedside as opposed to in a state lab from a blood spot. And because of that, there are 2 point of care tests out there, but the 50 or so other available ones are all done in the state lab. So because it wasn't a point of care test, I mean, that disqualified us, and then they found other stuff that went along with it, which I think all of us would stand up and say, hey, look, it is important to catch kids early. And we would, sort of pound him over the head with that if he kept on arguing against that. But the fact that it's not a point of care test. So what it did is it changed our mindset, and it made us realize that just because it's a RUS, just because you got the HHS and people that have big titles, we realized we are better than that system. Like we, as Ms. Harris said, she provided a solution that doesn't need them. And so we've expanded our thoughts, and the RUS for the federal group is one small group that sure, we'll work hard to satisfy as much as we can, but that's certainly, it shouldn't validate or invalidate us. There's so many other rich options to hit. The only thing is to have the federal government sort of validate it at that level is nice. It's a trophy. It's a badge of honor. But because it's a point of care test, I think we'd always be fighting an uphill battle, and we're obviously going to fight it. We're willing to fight it. And the more sort of shots on goal we get, the better. But what he taught us really, and if we had to think of his conversation as positive, which was probably hard to do while it was happening, but if we did think of his conversation as positive, he made us realize that the rest isn't all that. Like that is not the final say. And as creative people, we need to find alternative routes to get the information out.
Yeah, and I just want to say I appreciate those comments, and it makes sense to your presentation, right, in terms of a multi-pronged approach of how we're going to tackle this, because you said exactly what I was thinking, that the RUS is not the all be all say all for our standpoint, even as parents of someone of a child who has BA, and so I appreciate that a lot.
I'll just add that the reason we're not abandoning the RUSP initiative completely is because there is something in place called RUSP alignment legislation. Currently 12 states have this legislation enacted, and it simply means that any condition that's included on the RUSP, that state auto adds to their panel or auto considers on a 2-year timeline that condition being added to their state panel. So there is some value. If we make it on the RUSP in the next number of years, we would be auto included or auto considered in 12 states just like that. So just to give everybody a full picture, this is definitely that, like that one slide showed, a tripartite initiative. We're trying to, hit every avenue we can to make sure every baby gets the care they deserve early.
Dr. Rabbani, your hand was up.
Yeah, I actually just had a question. Did they give you any sense, and sorry, this is all before my time, but did the RUSP give you a sense, or do you have any prior knowledge from other diseases that have been added onto the RUSP? If you're able to get on at a state level, do they take that into consideration? Like, okay, we've done it in Montana, and it's successful there, then will they then take that into consideration, consider it at a higher value at that point?
It is a huge benefit to have that.
Okay, that's what I assumed, but I just wanted to, yeah. Okay.
Yeah, you have, input, honest and reliable input from other rare disease groups who've been through the process and who have landed on the RUSP eventually, that going the state route and having state data, helps them, because not only do they have the data from a program that's already working and successful, but they also have the providers in those states who come forward to the committee and provide testimony of the success and just the ease of implementation that they've had in their own, institutions. So absolutely.
Got it. Fantastic.
Sarah, I see your hand up.
Hi, yes, thank you. Question about the recommendations. Yes, biliary atresia is point of care testing. And you said they don't, other diseases that have been improved, they do it differently. There have obviously been other diseases diagnosed that also use point of care, right? Did they give you enough feedback to mirror or contact or research or seek out other diagnoses that use point of care that have also been improved?
Good question.
So yeah, excellent question. And we do know what those two conditions are, congenital heart disease and hearing screen. So you might remember your own children in the hospital, having the little headphones for the hearing screen, the monitor for the heart. So those are obviously not dried blood spot tests. What our understanding is, just at a very high level, is that both of those groups, it took them many, many, many years to convince the committee that this point of care test would be straightforward to implement at a state level. We are having early conversation right now with the hearing group. There was a joint committee that they put together more than a decade ago to make it on the RUSP and start getting rolled out in states, and they were very successful over a long period of time. So we're hopeful that those conversations in the coming months will shed some light on our situation, that their physicians can give us some insight into their processes, not just their policy processes, but their actual implementation protocol for doing something point of care as a screen.
Thank you. Like estimate, dry estimate, rough estimate, how many years did it take them?
Did it take their hearing group?
Yeah.
Oh, I'm reaching back in my memory here. It was well
What
over.
what was the question? What was the question?
How long it took the hearing group to make it on the RUSP. I know it was more than 5 years. It might have been closer to 10, but don't quote me on that. It was a long time.
That's okay, but not impossible.
No.
Not impossible. That's the key.
No.
Not impossible. And Kevin and I have some inside information. We talked to a guy in the CDC. I'm trying to remember. In the CDC, and he gave us some inside information a lot of those guys, they on that panel, they hate the cardiac screening. They don't want it on there. They think it was wrong, blah, blah, blah. Hearing is probably a great example. Hearing is, I think it's our model example, as you suggested, because that's tried and tested. It's everywhere. Everyone does it. It's very expensive, actually, if you look at the prices, and people still do it. They find it important enough. So that model of hearing was one of the avenues. Can we follow the hearing model to push our test through? So the strategy, it's I think it's a great strategy, certainly one that might have some wings.
I just want to follow up and add that I know I've mentioned the timeline to be included on panels many times and that it's years. I don't mean to say that as a deterrent to anyone who wants to be involved and join our advocacy work. In the newborn screen community, these years-long processes are accepted and well-known, and they are by no means a deterrent or a negative thing. It's just part of the system. A lot of these people who are involved are appointed and roll on and off with their appointments. A lot of them are volunteers. A lot of them are providers who are running their own clinics and on call at their hospitals and trying to do this in their spare time. So the processes are just understood to be long, but we're here for it.
Yep, you took the words right out of my mouth.
I like to think about it, how satisfying it's going to be.
Yes.
That in X amount of years, once we're on there, it's going to be so satisfying from all the hard work that everyone at Bear is doing.
We'll throw a big bear party somewhere when that happens. Yeah. So we have 5 minutes left. Brandy, I see your hand up, so I want to give you time to ask your question too. And thanks for joining us.
Yeah, of course. So just real quick, if we're talking about the false positives and everything, I think I'm in the group where I have a family member who has Alagille syndrome. And then I also, obviously have Teddy. If I were able to it's my step uncle who was born with Alagille. If I were able to get that information about his story and was able to share that in one of the, family advocate kind of things, would that be of any assistance?
So you really lead me into what I was going to wrap up with, and that's how to get involved, right? So this is perfect. And actually, Brandy, I will have to say this was one of my hot buttons when we were in the meeting with our application, because we had brought up that if not BA, there's Alagilles, there's PFIC, there are other pediatric cholestatic liver diseases that this could help and save more babies. And when that thought kind of got shot down a little bit, I think it bruised me just a smidge, because I'm so I am a huge proponent on if it's not one thing and you're catching something else, you're helping no matter what, right? So that totally that is a very good question, and that leads me into what we're looking to do next. And Maria had brought up about patient and family testimonies and how so important they're going to be moving forward, not only at the federal level at some of the meetings, which we try and attend every single one. And Maria, you can maybe speak to that, but then also testimonies too at the state level. And so if there's anything that you're willing to share, if you have a family member that's willing to share their journey and their story, and how their process went, you can actually, if you'd like, email, we have an email address. It's newbornscreening@bearinc.org. Please email us your story. Please let us know how you want to get involved. There's going to be so much more to come. This is one of our very first town hall meetings. There's going to be so much more to come that's going to be pushed out into the public, that we're going to start really bringing the community in to be able to help us, because Bear's not cannot work alone. We need your voices. And it's your lived experience that is going to help us push the needle and move this forward as we collaborate and work alongside with our physicians, right? And Maria, if you wanted to possibly add, because I know you are working on a lot of patient and family testimonies at the federal level when we go to those meetings.
Sure. I mean, I think you said it, that we're collecting testimonies now, and you can email those to us at the address Jen mentioned. We'll have that in a follow-up email if you didn't catch it. Some of you have already submitted testimonies, but what we'd like to have is a database of these testimonies so that as need arises for them, we can, preview them, contact you directly, ask you if you'd like, if you'd be interested in us publishing it, or if you'd be interested in sharing it in a public way at a virtual meeting or a live meeting in your state if we end up working on a coalition in your state. So absolutely, we'll take any testimony anytime.
And then I will say there is, last moment, and I did not see this, there is a question in the chat from Ashley and Taylor. How can we start local state advocacy to support the efforts? Okay, so basically what we're saying is to kind of stay tuned. Are there any Dr. Rabbani or Dr. Harpavad, any last minute thoughts, ideas?
I just want to, oh, go ahead, Sonny, sorry.
No, go ahead, Ted, after you.
Oh, I was just gonna say how impressed I am with everything that Bear's doing. And I want to say a huge thank you to the amazing family and advocates that are out there trying to push this forward. I'm just a lowly GI person over in California area, but it's really the power that you guys have here to do this at the state and federal level that's going to be so, so important. So I'm just very impressed when I see this incredible group of people working together towards this one common goal. So I want to say thank you to you all on the line right now, whether you're family members or advocates or part of the Bear organization for whatever reason. Thank you guys so, so, so much.
Right. And Sunny, did you have any last minutes, or are you good? I don't know how you're going to follow that one, so.
Yeah, no, well said, Ted. And I think the big story here is we're all working together. This is a process. I'm always so thankful because many of you have already sort of finished with biliary atresia. You're beyond that, and you're on the transplant journey now, and you're really doing this to help the next child. And for that, we're completely, totally grateful. And I think the one sort of pact we can all make with each other is we're in it for the long run. I don't think there's going to be a quick win. But if we're creative and we think broadly and persist, I think we're going to get this. Maybe I'm a little optimistic, but I think we're going to get it. So just kudos to Jen and Maria for leading the way and keeping us all patient. But I think patience is key. I think we're going to get it.
Well, thank you, and totally agree. And thank you all again tonight. I know it's 2 minutes after the hour, so I wanna be mindful of your time. So feel free, if you have any ideas, if you have patient family stories, lived experiences, newborn screening at bearinc.org, please send those our way. And then be on the lookout, for emails and social media push outs as far as what we're doing and moving this path forward. And, please help and spread the word too. I know we all talk to each other in one way or form on social media. And so if you feel like there's another family that you feel like would be, willing to get involved, please reach out to them and let them know about this, because this is really going to take a huge village to move this forward, but we're here for it and we're ready. So with that, I want to close and thank you guys for being here tonight, taking the time to be here, and more to come soon. Have a good night.
Thank you.
Thank you. Thank you.